All topics are very nice, presented by our eminent speakers. And in the second session, we have 6 lectures. Supposed to be starting with Dr. Faiza Haider, but because she have an family emergency, so we will start. And I am honored to introduce our first speaker, Dr. Anastasia. Dr. Anastasia is an orthopedic surgeon consultant. She is head of orthopedic department at Royal Hospital for Women and Children. She is tutor for sport and exercise medicine at the University of South Wales. She will talk about the neuromuscular adaptation to strength the training in children. Dr. Anastasia, the floor is for you.
Thank you, Dr. Salman, for the kind introduction and the invitation to be here today. First of all, before we begin, I would like to discuss with you all what's the purpose of this study. Well, as an orthopedic surgeon, my main goal, of course, is to treat all musculoskeletal disorders in children and in adults. But as a sports medicine physician, my goal and my passion is to create high-performance athletes here in Bahrain. So I need your help for that. As pediatricians, you are the first point of contact for parents and their children. So I would like you, please, to discuss with them and encourage them not only to be physically active, but to engage into sports activities as early as possible. So together, we can create the future champions of Bahrain. So let's start with our presentation, the neuromuscular adaptations to strength training in children. First of all, what is strength training? Strength training or resistance training is a type of physical exercise specializing in the use of resistance to induce muscular contraction, which builds strength and anaerobic endurance and increases the size of skeletal muscles. Now, the skeletal muscles have 2 types of muscle fibers. They are the slow twitch, or type 1, and the fast twitch, or type 2. The difference is that slow twitch muscle fibers support long-distance endurance activities, such as marathons, while fast twitch muscle fibers support fast, powerful movements, such as sprinting or weightlifting. Slow contraction fibers, type 1, have a high concentration of mitochondria and myoglobin. They are also shorter than fast-twitch fibers and are surrounded by many capillaries. This combination supports their ability for aerobic metabolism and resistance to fatigue, particularly important elements for prolonged exercise activities. Type 1 fibers produce less strength, have a slower production of maximum intensity compared to type 2 fibers, but are able to maintain long-term contractions. It is the key to stabilizing and controlling posture. Type 2 rapid contraction muscle fibers are divided into type 2B and 2A. Typically, they have a lower concentration of mitochondria, myoglobin, and capillaries than slow-twitch fibers and have a lower fatigue tolerance. They are larger in size and also produce more power faster, an important issue for power activities. Now, in this picture, we can see a long-distance runner will have more type 1 muscle fibers, whereas a short sprints runner will have type 2B. A runner of 400 or 800 meters will have more type 2A muscle fibers. Now, type 2B fibers produce the most power, but are incredibly inefficient due to their high myosin ATP activity, low oxidative capacity, and heavy dependence on anaerobic metabolism. Type 2A fibers are known as intermediate fibers. They could be considered to be a mixture of type 1 and type 2B with comparable strength. They can be used equally by the aerobic and anaerobic energy system. These fibers have a higher oxidative capacity and have increased fatigue strength compared with type 2B fibers. Now, what is a motor unit? A motor unit is made up of the nerve and all skeletal muscles it innervates. The motor units are divided into two types, the slow motor units and the rapid motor units. The slow motor units are small in size, and the rapid motor units are large. As the number of motor units that a child can use increases, so does its ability to produce muscle strength and to increase its maximum strength. At the same time, this maximum power can be achieved in a much shorter period of time, where in combination with the above, it allows this person to be able to produce more power. As the intensity and the requirement of the exercise increases, so does the number of mobilized motor units, which also leads to the activation of the type 2A and 2B fibers. For this reason, children should be included in a training program with high-intensity exercises or explosive ballistic exercises in order to get this adaptation, which will lead them to better functionality, physical and athletic performance. Now, in this picture, we can see a person with a sedentary life will have more type 1 muscle fibers, whereas an elite weightlifter or a person who trains with resistance training will have more type 2A muscle fibers, and a runner will have more type 1 muscle fibers. In children, muscular strength develops in parallel with normal development and is a result of maturation of the central nervous system. In the past, there were doubts as to whether children could actually improve their muscular strength, and early studies failed to show an improvement in muscular strength in pre-adolescent and adolescent boys. The potential for the poor improvement in muscular strength at these ages was attributed to hormonal factors because testosterone levels are low. Contrary to the above views, studies reported increases in upper limb muscular strength with the 5-hand grip test in 13-year-old children after the implementation of the isometric training program, while Hendiger reported increases of up to 4% per week in the isometric strength of the extensor and flexor muscles of the arm in children aged 12 years after an isometric training program. Improvements in the isometric strength of the knee extensor and flexor muscles in pre-adolescent boys and girls were also found after an isometric workout program. Corresponding improvements were also reported in performance tests requiring upper body and arm strength in pre-adolescent children after the implementation of cycling training, which included muscular empowerment exercises. The results of newer studies with better experimental design also prove the effectiveness of muscular strength training in improving muscular strength in adolescence. Isometric training caused a significant increase in isometric muscular strength in the knee area in a group consisting of pre-adolescent children. Pfeiffer and Francis found greater improvement in pre-adolescents in dynamic upper and lower limb muscular strength than in adolescents after applying a 9-week training to boys of the pre-adolescent, adolescent, and post-adolescent age. Improvements in upper and lower extremity muscular strength have also been reported by Sewell and Micheli after applying vigorous resistance training at 9 and 14 weeks, respectively, to pre-adolescent boys, and especially designed resistance instruments for children. Fogg and Tenenbaum, in a review of their literature about the effectiveness of resistance training in children, report that resistance training may be effective in increasing strength in pre-adolescents and adolescents. Analyzing the existing literature of 28 studies describing resistance training programs for girls and boys under 12 and 13 years of age, they found that only 9 of these studies provided the necessary data to calculate the magnitude of the effect these training programs could have. The majority of studies, however, showed gains in muscular strength between 13 and up to 30%. The neuromuscular performance of pre-adolescent children differs significantly from that of adults. It is generally documented that mechanical loading cumulatively with the effect of maturation improves muscle strength in childhood. This improvement is mainly considered the result of neuromuscular adaptations, although there is evidence of morphological adaptations too. For example, artistic gymnasts with a mean age of 9.5 years were compared with untrained children and untrained adult men, and found that gymnasts had a similar level of torque development when bending elbows with adult untrained men, and an overall 20% higher rate of torque development than their untrained peers, despite the absence of greater muscle hypertrophy. The researchers attributed this finding to the higher levels of motor unit stimulation and the increased mobilization of type 2 muscle fibers in young athletes due to chronic gymnastics training. Due to the limitation of taking muscle biopsies in children, data on muscle composition in children are scarce. Few studies show that children have a higher percentage of oxidative fibers compared to adults. Also, type 2 muscle fibers in children appear to be smaller in cross-sectional area than type 1 fibers, which probably indicates reduced activation and use of type 2 motor units in childhood. It is found that children's type 1 muscle fibers are more tolerant to fatigue, and that children have a higher rate of type 1 muscle fibers, which is reduced gradually from the age of 5. Now, the athletic performance depends on 2 key areas: neuromuscular adaptations and hypertrophy of physical abilities. Neuromuscular adaptations begin at the age of about 10 years and peak at the age of 16 to 17 years. For example, in order to play football, children between the ages of 10 and 15 must have completed their neuromuscular adjustments. Such adjustments are all those that concern the technique of football. All this can be completed by the age of 15. So at this age, the young footballer will have learned all football skills. Muscle hypertrophy, which is the development of muscle strength, begins at the age of 12 to 13 with a small increase. From the age of 14, the increase shows a jump till the age of 18, and then follows a slow development that cannot exceed 5%. This small percentage, in combination with the technique but also the construction of the body of each athlete, is what makes the difference. Through the improvement of physical abilities, the best performance is achieved in all sports. Strength training, weight training with low to high loads can improve both maximum strength and jumping ability. Also, the improvement of maximum power is greater with the use of high loads, while the improvement of jumping ability is greater with the use of low to medium loads. In addition to the load, the pace of exercise seems to play an important role. Ballistic training with weights up to 30 to 90% of one repetition max brings improvement of both maximum strength and jumping ability, while it seems to prevail over weight training in improving jumping ability. Ballistic training with 30% of either the maximum isometric or one maximum rep seems to prevail over high load training in improving jumping ability. A comparison between weight training and ballistic training over a wide range of loads will lead to useful conclusions about the most appropriate training program design. In conclusion, the necessity of strength training at a young age is one of the key components of functional training, with the goal of improving performance in sports. The first step is to introduce to the children each sport and let them explore their body function in space and time. There are many exercises that improve and initially develop neuromuscular fitting due to the involvement of many muscle groups that work together. Much of the planning in strength training should include exercises to stabilize the core as the most important part of the body's function. Strength training plays the most important role for an athlete to stand out. Many athletes and coaches are unaware of how important strength is in all sports. Research clearly shows that strength training on season helps maintain the high level of athletic readiness and helps to prevent injuries. Young athletes should follow modern training methods to maximize neuromuscular adaptations. They need to understand the neuromuscular mechanisms associated with improving athletic performance, but also with preventing sports injuries, as well as the importance of training to maximize neuromuscular adaptations. In particular, both young athletes and their coaches should be aware of the function of the neuromuscular system, methods of evaluating the neuromuscular function, methods of improving neuromuscular function, methods of improving neuromuscular performance, and finally, mechanisms of neuromuscular fatigue and ways of handling them. The message to take home: the development of strength with known methods of resistance training can positively affect athletic performance. There are significant neuromuscular adaptations to strength training in children. However, we need more studies to focus in young athletes to offer a framework for better knowledge and understanding of the mechanisms behind the adaptations. This will ensure that young athletes, trainers, coaches, and parents will have a better understanding of the physiological changes and demands, which will enhance performance and injury prevention. Our job as physicians is to motivate the children of Bahrain to engage into sports and become the future champions and Olympians. Thank you for your attention.
Thank you, doctor. Is there any question? Yeah.
Sorry? You can hear me? Yes, I can hear you, of course.
Okay. Thank you, doctor, for your nice presentation. Is there any evidence, scientific evidence, I mean, that isometric exercise can affect kids growing like height growing?
Sorry, say again.
Is there any scientific evidence that isometric exercise like weightlifting can affect the growing of kids, especially for height?
Like you said, you mean to prevent getting taller?
Yeah, you are right. Yeah, that's what I mean, yes.
Yes, weightlifting, especially weightlifting, is not recommended to start at an early age. I urged you before to discuss with the parents and their children to start sports as early as possible, but that should be at an introductory stage, not as a competitive sport. So especially for weightlifting, we would say that the introduction should be after the age of 8, and then for competitive sport, weightlifting, should be after the age of 12. You're welcome.
Any other question? During the last 2 years, our children are using this sedentary life because of the COVID, and even the learning are online, and they are not active during the last 2 years. Exactly. So does this have an effect, especially those who's at the age of between 10 to 14 years old? If they want to back to the normal life and to be an athletic, how we can, again, to promote them and to develop a neuromuscular system for them?
Yes, that's a great question. Actually, these past months we have seen so many different types of injuries in children, neck pain, back pain, all these because of the 2 years of quarantine. So now the key is to help those children to go back gradually to the normal life, to start being active, and go out and play, of course, but also engage into more organized sports. The best idea is to allow them to try whatever they prefer. So offer them as many options for physical activity as possible, and then let them decide what is best for them.
Any other question? And I think online we have around 100, but there is no any question from the Zoom audience. Thank you, doctor.
Thank you.
Thank you. So we'll move to second speaker, and my honor to introduce Dr. Tarak Madawi, consultant psychiatric. Dr. Tarak is a well-known speaker in an local, regional, and international conference. He was on the head of psychiatric department in International Hospital of Bahrain, head of psychiatric department in Ministry of Interior, and he participated in many conferences. Currently, he's working in a private clinic in Royal Hospital for Maternity and Children, and he will presenting the children up, bringing mental health. Dr. Tarak, it's my pleasure to be with you today.
Thank you very much for the great introduction. Assalamu alaikum. Today, inshallah, we're going to talk about children upgrading methods. Before starting to talk, usually I'd like to put some lights on what is mental health. Actually, mental health is how we feel, how we think, how we act in order to face the events and situations. It's how we look to ourselves, our lives, people we care about, and no. Mental health also helps to determine how we handle stress, relate to others, evaluate our options, and make our choices. So what about child mental health? Child mental health is the complete well-being and optimal development of a child from the emotional, behavioral, social, and cognitive domains. So by mental health, the old definition of mental health is not having mental illness. Currently, it is more broad, in more comprehensive definition of mental health. Mental health of children depends to a large extent on the way parents interact with them. There is no proof that there is a method that is excellent, the best method of upbringing. We have many types of upbringing procedures or methods we're going to talk and discuss after a few minutes, but we have to know that there is a great differences between each child. Individual, cultural, gender, societal differences affect also the upbringing. We have four main types of upbringing system of parenting upbringing. These four methods depend on two factors: parental warmth and parental control. The first method, we call it the authoritarian parenting. It's high on control, low on warmth. So high control, inadequate love. Here the child is expected to follow rules. Following rules without any explanation. No discussions. The child doesn't know why he has to follow this rule or these rules. Failure leads to punishment, not consequences. So if the child fails to comply with the rules, he is going to be punished, regardless anything else. Parents here are so strict. Most of the time, they push the child to do their own rules, as I mentioned, without any explanation. The child here, or children here, typically obedient, compliant, reliable, proficient, but we have to remember that for fully developed personality, freedom is needed. We have to have some kind of freedom while we grow up. Freedom to think, freedom to discuss. So here there is no freedom. There is no independence. There is no autonomy. So children raised by this way become highly dependent and develop severe anxiety or depression under situations where they have to take decisions, because they are not trained to take decisions. They are trained to obey orders. That's it. No choices. He can't think about choices. Putting that child in a stress, in a situation, needs to think. He is not trained to think. He is trained to obey. So they become less socially competent with very low self-esteem, because they believe that they know they can't do anything without being pushed to do it. He has to obey rules and no discussions, so very low self-esteem. Such children can never achieve the expected goals. The wonderful presentation we heard regarding exercising, we all know that exercising, regular exercising in particular, improves the mood of children, adolescents, everyone. But till a few years ago, we didn't know why. There was a lot of speculations, maybe because of the endorphins, maybe because of the serotonin, maybe we didn't know. Actually, till 6-7 years ago, we have found that on doing functional imaging of the brain for those having stress, anxiety, depression, we see something like an inflammatory process in either the amygdala or the hippocampus. Inflammation. We don't have white blood cells in the brain, right? There is no white blood cells, which are the anti-inflammatory cells in the body. We have another cells called microglia. It has been proved that the only thing activating the microglia is regular exercise. So for us, it was a breakthrough. Finally, we know why. When we were young, junior residents, we used to go to one of our great professors. He's still, mashallah, active in his 90s. He has his own hospital. We used to go so early. He was telling us, those who want to attend the clinic and seeing the patients with me, come early. So we used to go early. He was all the time sitting on a chair beside the hospital, letting the patients running. And the one who doesn't, hitting him. So we used to say, what is he going to do? Why? So we used to ask him, why? No. His answer, I don't know. But he noticed that those who exercise needs less medication, less duration of stay in hospital. So authoritarian parenting don't allow children to exercise. So because no, strict. So in terms of personality, over strictness kills the spirit of freedom in children. Children get the wrong ideas that being free, independent is undesirable. Children raised by this parenting style may become very hostile and aggressive. We call it a reaction formation in psychology. They used to be obedient and compliant, but when they grow up, they become hostile, aggressive. And they tend to play secondary roles in any activities. He can't lead. He can't be a leader in any way. He is always inferior. So this is the first method of parenting upbringing. I love this one, the authoritative parenting. Here you have high control, but high warmth, high love. So we consider it the best parenting style, because good control with good love. So parents here are less strict, but when they give any instruction, they explain, they negotiate with the child, so the child can understand why he is going to be punished and why he is going to be rewarded. And there is always some sort of compromise. I'm sitting with my child, discussing with him, explaining to him why I'm putting this rule, and we can negotiate it. We can talk about it. So parents here establish rules for their children with explanation. Listen to children's questions and negotiate compromises. Authoritative parents tend to use consequences rather than punishment. In the first style, the authoritarian, punishment, no consequences. Parents here are less harsh, more understanding, more forgiving. Parents here also differentiate between the child as a person from child's behavior, on the other hand. We always, when we see children in our clinic, when we sit with the parents, any kind of problem child is having, we are always telling the parents, give the child the information and message that you don't hate him. Maybe you hate his behavior. You don't dislike him, you dislike his behavior. Don't tell him you are stupid. Tell him this is a stupid behavior. Completely different message to get for the child in his emotional development. Parents here differentiate, parents here are giving rewarding children for desirable behavior, withdraws rewards as a punishment. This is the best way, by the way, in punishment and reward. Give him something he likes, seeing a movie, playing with his children, with his friends, but no physical punishment, no verbal abuse or punishment. We call it child abuse. So, okay, punish him, but by withdrawing the things that the child likes to do. And the child has to be aware that this is my punishment because I did so and so and so. In the authoritative parenting, parents should be consistent in their reactions. Because one of a very common fault, actually, that I am punishing my child for something, but his mom is not. So conflicting messages. What's wrong and what's right? Why he is punishing me and she is not? Even with this kind of good punishment, but punishment should be persistent. And we have to have some sort of an agreement as a family, parents, father and mother, how to reward and how to punish. So the child is not going to get conflicting messages. One of the theories of schizophrenia in children, conflicting messages in childhood. Imagine schizophrenia, which is typical biological problem, but it's biopsychosocial. But one of the psychological problems occurring with children getting conflicting messages, that as if they have split mind. This is right, tomorrow this is wrong. So conflicting messages. So again, it should be consistent in their reactions. A very important point here as well, the child, when punished, understands that the parents still love him as a person. Children raised by this discipline tend to be happy, successful in life generally, very good in making decisions and choices, and they can evaluate safety and risks on their own. They grow up to be responsible adults, confident, capable, competent, and socially well adjusted. In terms of personality, when a child raised by this discipline, he feels that parents contain him. He experiences a sense of safety and happiness. Maybe we remember Maslow's hierarchy of needs. I don't know whether you're familiar with Maslow's hierarchy of needs. It talks about self-actualization. Any person needs to reach the self-actualization. He put the basic needs in the beginning, food, shelter, the basic needs, but the second need for a person to develop, to reach the self-actualization, sense of safety. Safety, security, emotional safety, physical safety. So safety here is very important. So the child grows up with very good self-esteem. Children raised by this pattern become good and caring parents. So it is learned behavior. They are learned to do so and so and so. So that's why this is one of the best methods. Good control with good love. The third pattern of upbringing, we call it permissive parenting. Low in control, high in love. So parents make very few demands on their children, rarely discipline, tend to be lenient, and may only step when there is a serious problem. Lots of love without adequate control. Reward and punishment are the only way, or two ways, to make the child discriminate between right and wrong. So here, there is no reward and no punishment. maybe a lot of rewards for anything, but no punishment. So the child will never be able, while facing anything, right or wrong. And a very common fault here, that there is inconsistent punishment, if there is any punishment. We mentioned this before, inconsistent punishment. Children raised by permissive parents or parenting are often unhappy adults. And they don't know how to obey rules. So usually, researchers found that children raised by this method become antisocial or criminal. A lot of antisocial and criminal behavior patterns like substance abuse. When we take history, permissive kind of parenting. We saw it, most of the substance abusers coming to our clinic, most of them raised by this method. Inconsistent punishment and permissive parenting. Very high love, no control. So those with no control, I saw one patient, unfortunately, I saw his mom coming with fractures. Give me money. When she started to say no, no, I'm not used to hear no. He pushed her and he did what he did. Substance abuse, antisocial behavior, because he raised by no control and high love, who used to take, not to give anything. So, in terms of personality, children raised by permissive parents or parenting are often unhappy adults. They have low self-esteem and may report a lot of sadness. They have poor self-regulation because they are not used to have any kind of self-control or self-regulation. Many experience problems with authority because they didn't feel that there is some kind of authority on them. So they don't appreciate rules, and they tend to struggle academically by performing very poorly in school and then in workplaces. These children are likely to become spoiled and would manifest, again, antisocial criminal behavior pattern. The last one, uninvolved parenting. Low in control, low in love. It's called negligent parenting. Few demands, rare communications, and unresponsive to the needs of their children. The essential needs are met, yes, but the emotional needs, there is no emotional needs met here. Neglected. Almost no rules or expectations, no guidance, no parental attention. So we call it emotional vacuum. Children raised by uninvolved parents have the worst outcome in all areas of life. They cannot become good adults or good parents. So in terms of personality, children raised by uninvolved parents have the worst outcome, as I mentioned, in all areas of life. Emotional well-being, life satisfaction, success in relationships, success at school, work, and so on. They lack self-control, the majority have very low self-esteem as well, and they tend to be less competent in social and practical life situations. Emotionally deprived children cannot become good parents or good partners in marital life. When parents are uninvolved, children tend to perform very poorly academically and rank low in happiness. How to determine a discipline strategy? By the way, most of the times, not sometimes, parents do not fit into just one category. Sometimes authoritarian, sometimes authoritative, sometimes permissive, according to the child's needs. We should be like this, flexible, not taking only one style. Because children differ. Maybe the twins, they differ. So we have to adapt our strategy according to our child needs. When determining disciplinary strategy, it's important to think about what it is that you want your child to be, to learn, to know, to understand. So it depends on our child. Effective discipline strategies can teach children to become responsible adults who are able to make healthy decisions on their own. Parenting without control or without love is a disaster and definitely undesirable. I think here we end. Thank you very much.
Thank you, Dr. Tarak, for this. Yeah, it's on time. Actually, it is very interesting presentation, and it is as an not as a doctor, as a parent, should say you are open our mind how we are dealing with our kids.
I thought this year let us make about something regarding development, parenting, not every time childhood depression, OCD, attention deficit. So I thought let us talk about parenting styles.
Yeah, exactly. It's very important, and I think all of us, we are using the mix. I think maybe neglecting no, but the others are, we are sometimes moving from one category to other. And regarding, I have one question regarding the conflict message.
Regarding?
Conflicting message. Conflicting message.
Forgetting?
Conflicting.
Conflicting.
Yeah. There is a global sound of the homosexuality in the world. And as per our religion and per our, we are against this one. So our kids now, they seeing the world are talking different and we are talking different. How this will affect their future? And you mentioned that this may be lead to the, even the disciplined mind. So it's how we can send the right message for them.
In my practice, I'm faced with similar situations a lot. Parents coming, telling me, doctor, my child or adolescent is bringing his friend, telling me, this is my best friend, but mom, he is home. So the mother got panic. He's telling her, what's wrong with you? This is his choice. We are in free world. I'm hearing this a lot. My advice to the parents to tell, okay, but we have some cultural and social norms. You have to be aware of it. That there is cultural norms and social norms and religious norms as well. So you have to take your decision, okay, whether to continue with him as a friend, to respect him as a person, but not to agree. There is a difference between understanding and agreeing. So try to, and the earliest is better. I'm not going to talk about this with my son who's in his late 20s and got the fixation of the messages in his ideology. So this is my usual advice, to explain the social norms, the cultural norms, the religious norms.
Yes, if nobody else has a question, or the online audience. I would like to ask you, please, as a case scenario, let's say, parents who are not authoritative or permissive, like authoritarian, like how do you call them? Like they have a good amount of authority, but also they have lots of love and control, and they are well balanced. But they keep on repeating to their child, when you become 18, you can do anything you want. And this child turns 18, and she drops out of school, and she doesn't listen to anything else. She wants to live alone. She doesn't want to study as per the family. How would you advise these parents?
Actually, I can't say that these are typical authoritative, because for adequate love, we have to explain to our children the future-wise. Okay, when you become 18, you'll take your choices, but we are still there. And we have to agree, because he's still living with his parents in our culture. I mean, he's still living with his parents. He is depending on them for his needs, physical and emotional and everything. So I can say, if I'm going to say to my child, when you reach 18, do whatever you want, this is low control. This is not adequate control. I'm giving him that I'm going to be permissive. So this is another conflicting message. Why? Yes. I'm always here and then permissive. So it needs some sort of adjustment in the way we explain to our children our expectations from them, and let them to be happy to reach their expectations with our expectations as well.
Thank you.
Welcome.
Thank you, Dr. Aap. Thank you.
Thank you very much.
Thank you.
It's my pleasure.
We will move to the next speaker, and I think it will be a recorded lecture. Online? Yeah, it will be online. Dr. Najla Jassas, she is an pediatric endocrinologist for the last 16 years. She is working in King Fahd Military Medical City and also working in King Fahd Specialist Hospital in Dammam and in Dr. Sulaiman Al Habib Medical Group. She will talk about a very interesting topic, the pediatric diabetic ketoacidosis. Dr. Najla, if you hear us, you can start.
Yes, sure. Assalamu alaikum. Good afternoon. Thank you, Chairman, for this introduction. It's my pleasure to be with you, and sorry it's Friday afternoon. So as we start in the morning about pediatric endocrine emergency, that we defer the commonest emergency in pediatric endocrinology to be afternoon in a separate session. So I will go through brief about pediatric diabetic ketoacidosis. As I mentioned in the morning, that diabetes is the commonest, and really when the patient undiagnosed or presented with severe DKA or he has a risk of cerebral dysfunction, and he needs to be tackled as a major emergency. I will start today with a small, just brief case, then recognize the clinical feature of DKA discuss the pathogenesis, how to treat our patient and monitor diabetic ketoacidosis case, which is the key actually in management. Recognize the potential complication, how to prevent if we can, sick days, conclusion, and references. So simply, the case is a 7-year-old boy with acute abdominal pain and vomiting brought to general practitioner by his mom. And this is a common scenario, really. He was being bullied at school because his mother attributed his recent onset of bedwetting to stress. She did not mention this symptom to the general practitioner. So what is the first investigation? It was actually basically urine. It will be the first, having bedwetting history. So urine test done for this patient, it came to be positive for glucose and ketone. Initially, because of the predominance of gastrointestinal symptoms and the abdomen, they contributed initially could be acute abdomen. But with the presence of glucose, next step come. So glucose check has been done and it has to be 500. So patient immediately diagnosis was changed to newly diagnosed diabetes with ketonuria and referred to emergency for investigation and management for the possibility of diabetic ketoacidosis. So what is from this case introduction, I will go to the common presentation of newly diagnosed diabetes when they presented with common symptoms like abdominal, especially with DKA symptoms, mainly gastrointestinal, like nausea, abdominal pain, and vomiting. And for that, the history of polyuria and polydipsia is a key. And many times it's been missed initially just because of it was well attributed in many occasions as acute abdomen when they presented in this scenario. When they present initially, the symptoms always the classic symptoms of diabetes patient: polyuria, polydipsia, weight loss, fatigue, nocturnal enuresis, vision blaring. They do have eventually UTI, commonly UTI, vaginal candidiasis, abdominal pain, vomiting, ketone breath, and cosmal breathing. The initial workup to be done for those patients: glucose, urine analysis, blood gas, blood urea nitrogen. Classically type 1, they do have low C-peptide because usually commonly we do it because of the raising now of obesity in kids and raising of type 2 diabetes. So we have to differentiate, along with antibodies for type 1 diabetes. This is our initial workup for our patients. The diagnostic criteria for pediatric diabetes when it comes to fasting glucose more than 126, and actually diabetes would be in all occasions above 200 milligram per deciliter. Rest of numbers, this is for the impaired and normal range. So classically diabetes diagnosed when you have a sugar more than 126 and in fasting state and random state 200, along with classic symptoms of polyuria, polydipsia. What are the diagnostic criteria for diabetic ketoacidosis? We have to classify them actually mild, moderate, and severe. And it need, first of all, in all occasions, sugar will be more than 200. Sometimes we have overlap with hyperosmolar state when the sugar comes to up more than 600. And in all occasions, DKA started to be defined with pH of less than 7.3. Then the severity based on less further pH monitor between 7.1 to 7.2. We are talking about moderate. Below 7.1, this is, and bicarb below 5. This is the time when you diagnose him as severe diabetic ketoacidosis, along with consideration in the mental status as well. What is the pathogenesis behind all this clinical presentation we see? We see acidosis, dehydration. So the status of insulin deficiency state, really it's a state of stress when the patient have actually all the counteracting hormone comes up to elevate the sugar further and to work up because the cells are hungry. Along with polyuria, polydipsia, when you have the polyuria, patient will lose. We have glucosuria, he will be dehydrated, the patient. So you will have a combination of dehydration, a combination of hyperglycemia. You have further pressure on the counteracting hormone to work, so further hyperglycemia. They start the abdomen, the body started to use the alternative fuel, which is the ketone. So the breakdown of the fat happening, then ketoacidosis journey start. For that, it's a progression from hyperglycemia, dehydration, and for ketone and ketoacidosis formation, it's the steps indicates severe insulin deficiency state. In children with in children who presented with diabetic ketoacidosis, the risk of DKA is established diabetic is around 1 to 10% per year. And the risk is increased for children who are omit insulin, who have long-standing poorly metabolic control with recurrent DKA, who has gastrointestinal illness with persistent vomiting and inability to maintain hydration. For that, one of the rules always we are telling parents that they have to come early when there is vomiting. Part of the management to prevent DKA when they have gastrointestinal illness, to come early to hospital to hydrate and to monitor and to ensure their oral intake. Children with psychiatric disorders, children with difficult social circumstances is a huge pressure. Those patients who have unstable social life and the coping very difficult, and patient adolescent age group is difficult also, and they are prone to DKA. Children with limited access to medical services. Those are at the risk for patients who are established to be type 1 diabetes. Common the frequency more in the age of the disease of onset, because the patient not on treatment. For that now, we know that we cannot tap to the incidence still of type 1 diabetes rising, despite all effort and to know the etiology behind it. Still we are lacking, and we have incidence rise further over the last 2 years and getting more in toward preschool kids and small toddlers as well. So basically with this we cannot prevent diabetes, so type 1 up to this moment. So the only way is to prevent it by alert or educating the population about the symptoms of diabetes, so they can present the patient from early onset with polyuria, polydipsia, to pick the patient up and to prevent DKA. This is the only way now at this stage to help in preventing or decreasing DKA on those patients. The DKA at diagnosis more commonly in young age group, less than 2 years, because of late presentation. It will be hard for the family to recognize their symptoms. The principle of DKA management, actually it's further steps. First of all, it will start by mainly rehydrate patient, manage acidosis, then manage hyperglycemia, treat the precipitating factor. This is and try to prevent complication by close monitoring of those patients. Nothing I found it really perfect in managing DKA patients more than following protocol and keeping eye on patient to be on monitored. Patient, whatever when we start the protocol of DKA, this patient it's only a guide, the protocol. After that, it has to have a close monitor, nurse hourly check, monitoring clinically, physician on top of the result and clinical assessment, monitoring and picking up the complication. It will be the best and management for those patients. For the really DKA management, the key of a treatment of those patients safely without complication is to have a close monitoring setup. This is the algorithm for SBAD guideline, and it was the latest in 2018. We are spending 2020, not revised yet, but supposed to be for publication. We are waiting for it. Supposed to be this year, but this is the moment. This is the final the final guideline that has been published. It's very nice actually guide and simple algorithm to go through DKA patients. The patient basically, when you classify him as mild, moderate, severe, go with mild DKA patients. Mild DKA patient with good oral intake, try to start with sub-Q simply and continue oral hydration. If you fail, this is the time if the pH got worse or the patient clinically start to vomit, you will switch him to IV therapy. Once patient he has vomiting and more than 5% dehydration, as in you have to move to IV therapy. Always IV therapy will start with normal saline 10 ml per kg over 1 hour. Try to avoid rapid correction unless the patient in shock, and always to treat this patient as hypertonic dehydration with deficit to be corrected over 48 hours. This is the safe for those patients to be slowly going slowly back to normal. Rapid hydration really will alter the osmolality and will contribute to complications like cerebral edema. First hour, it has to be only fluid. Second hour, you will add the insulin infusion. No room for insulin boluses IV for those patients. And you will start insulin infusion typically second hour, not first hour, because this is, you will go, again, you will give a room for a gradual reduction of osmolality. Once patient in shock, you will be more aggressive. ABC, 10 to 20 ml per kg normal saline, can't be more rapid, but really senior staff has to be on board for those patients. With era of epidemic of pediatric obesity, many and type 1 diabetes is still common in this age group. So basically, if you have an obese child or overweighted child with diabetes, when we don't know the etiology, is it 1 or 2, but presented with acidosis, DKA, he has to be treated as type 1 diabetes still. During the follow-up, the result will show up. But when he presented sick, acidotic, we will not look at the type. Immediately, patient will treat it as DKA, regardless of the underlying type of diabetes. Hyperosmolar state, commonly we see it in type 2, and usually they are not acidotic, and they are mainly hyperosmolar, more than 600. And sometimes we do see overlap, DKA and hyperosmolar. For those patients, we have to be more gradual and more careful. Complication during a treatment, when you see it, actually it's mainly what we consider, although despite it's quite rare, but if it happened, it contributes to the major cause of death, which is cerebral edema. Commonly we see hypokalemia. For that, with the fluid deficit, when you start the fluid deficit post-maintenance, with the second hour, you will add the potassium. If the patient void or has no renal impairment, and immediately you will start 40 mg per liter potassium, because the potassium will go farther as insulin infusion started. This is the way to monitor. You will monitor electrolyte Q2 to 4 hours to see how we are with management. Commonly, we do see hyperchloremic acidosis, which is normal anion gap metabolic acidosis, away from the normal high anion gap of DKA. And this is mainly due to high infusion rate of normal saline with the chloride. But that's why usually we do patient, they are prone for that. If you have patient with persistent acidosis and the patient clinically improving, just sit and calculate the anion gap, see where we are. If you are dealing with normal anion gap, it will be a different entity from we have high anion gap with DKA acidosis. Hypoglycemia and inadequate rehydration, very important complication. As I mentioned, really the key of managing those patients is a close monitoring. For that, always the idea, each hospital have guideline for DKA, when to admit patient, and because it depends on the experience, setup, and the availability of expert staff. There are hospitals with even patients with mild DKA go to the ICU for the sake no expert staff, for example, or experienced nurses in the floor. Or there are other hospital, depends on their protocol. They do admit patients to mild to moderate DKA in the ward and severe DKA in the ICU. That depends on the hospital setup, but all what we need is a close monitoring of those patients. The key is to prevent, if we can, and how we can prevent, they will talk about it later in the subsequent slides. This is the diabetes flow sheet from British Columbia Hospital about the monitoring of patients during hospitalization for DKA. You need vital sign, Glasgow Coma Scale, neuro assessment, along with the electrolyte, glucose, urine output, and so on. As I mentioned, cerebral edema is very, mortality rate from it is very rare, but if it happens, it will cause actually cerebral edema account for 60 to 90% of all DKA deaths, although in general the mortality rate is low. The signs of cerebral edema that patient need to be warned, as I mentioned, during monitoring, we have to watch the neuro observation of those patients, new onset of headache, new onset of enuresis, irritability, sudden incontinence, or other neurological sign like cranial nerve palsy, papillary edema, and so on. We should not wait till see vital sign disturbance like bradycardia or hypertension, because it's when advanced edema and it's ominous sign really. So we have with onset of symptoms, we have to act. Basically, what we do when we have these symptoms, we check glucose immediately. If the patient not hypoglycemic and not contributed to hypoglycemia, his headache or irritability, we will move on as we will give mannitol. After that, we will cut the fluid to maintenance rate and we elevate the bed. And after stabilization, this is the time we do cranial imaging. So first line, mannitol. Second line, we will give we will intubate if patient needed it. So if he has low Glasgow coma scale. What contribute to cerebral edema? Many factors actually. They said the rapid drop in sodium, rapid drop in failure of sodium to rise, because what we call is actually absence of positive sodium trend, and two, rapid drop in osmolality, use of bicarb. There's many theory behind it. But there are actually what I've mentioned, that we have to be slow, treat as hypertonic dehydration, avoid bicarb for sure, go correct with acidosis with fluid and insulin slowly, monitor your patient, and try not to avoid double maintenance per day for sure. The prevention is by warning the society about the symptoms of diabetes, which is called 3B, polyuria, polydipsia, polyphagia, non-alarm, and how in established diabetic kid, how to prevent DKA on them by good close monitoring, try to control patients, try to look for comorbidity, how to support him. And the same day, in the same time, how to educate the patient, how to take care of himself and the family, how to take care of sick days. Because sick days, the patient if he has infection and he's late to the hospital, he will have DKA. Many parents, they do scare from giving insulin when the patient is sick and he has poor oral intake. We will tell them, no, you have no way to stop insulin. Don't stop, but bring early the patient to the hospital. The 6 days rule, check sugar more frequently, give insulin, don't omit insulin, drink lots of fluid, check ketone at home. If the patient ketotic, to give extra insulin, extra fluid, as per guided by the primary physician. Then if the patient not improved, to come to the hospital. And I tell them, whenever a patient has poor oral intake or vomiting, don't omit insulin, come to the hospital to interfere early. Awareness of symptoms, of course, of hyper and hypoglycemia. This is the 6 days instruction, don't stop insulin, increase glucose check, keep your supply, glucagon kit to be available, glucometer, and to sugar-free fluids, and to have insulin patient on pump. Actually, they have to have insulin bins with them at home in case of pump failure or malfunction, immediately to switch to bin to prevent decay. And this is from Royal Children's Hospital about the step when the patient have acute hyperglycemia. It's a phone call, and when they call the patient, how to have the patient could be contacted, the educator for my child has hyperglycemia more than 15 or more than 250 milligram per deciliter. What shall I do? So history taken. If there is vomiting, we'll bring him really. If no vomiting and stable, the patient can, we check ketone, give extra insulin for the ketone. If improved, well and fine. If not, to come to the hospital. One of the common error that I found in our patients who are poorly controlled, they use the abnormal injection sites, and this contributing to poor control and high sugar. Basically, most of the kids, they tell me, it's not painful, for that we use it, especially the adolescent who inject themselves. But we have to look at the site, we have to emphasize that it's not healthy, it could contribute to poor control, and we have to have a healthy access. The other area, actually, about the incidence rise of double diabetes, which is insulin resistance due to obesity. So we are dealing actually with both type 1 diabetes and obesity, which create insulin resistant state. And it's really challenging for us to tackle two issues in the same patient. So we have to have those patients need more monitoring, more control toward weight, more counseling, more help as well. So when I conclude that patient actually with for type 1 diabetes, early diagnosis, prevent DKA as a presentation. I presented the algorithm of DKA guideline from ISPAD. The DKA on diabetes management in general need a teamwork. need educator, dietitian, psychological, social, expert physicians that need actually money. It's never been a one-man show. So we need a well-educated, well-supportive teamwork. Education and continuous education for those patients is the hope to cope and to help them. They have to be educated about sick days rule. We have to have multidisciplinary team to take care of those patients. Follow up regularly in well-controlled patients every 3 months minimum, while more frequent follow-up for patients who have other issues or poorly controlled. And we have to keep eye on double diabetes, which is obesity and type 1, to take care and to prevent complication. I hope this time I finish on time, so thank you very much.
Thank you so much. Your presentation was very interesting, very informative, and very accurate. Any questions? No questions?
Yeah, I have if you allow me, I have 2 questions in my area.
Yes.
I can mention the question I have. Is it okay? So there is here I have a question. After Beacon study, the association of rate of the fluid administration, cerebral edema, has been reported to lots lesser than assumed. Is it the idea? Is there a change in fluid administration now in the guideline? Yeah, I went through it. Yeah, you are right. We are waiting for the new published guideline this year. But many reports now coming about the that it's not associated with the brain edema. But still, you know, keeping in mind for this that we have to be careful with those patients. Those patients, they are hypertonic. The more slow, the more you are safe. I will not be aggressive with the fluid therapy unless my patient in shock and need. But to treat as simply as hypertonic dehydration, get them be slowly back to normal. Yeah. The second question, SARS-CoV association of DKA incidence. What is the experience of the presenter? Okay, thank you. Thank you for this question. COVID and endocrine issues has been reported quietly during COVID. And we have many issues with diabetic in COVID season. So you have 2 things with COVID. You have one, if the diabetic child has COVID infection, or if the diabetic child lost the follow-up because of season and lost his medical support. We have 2. It's found that first of all, regarding incidence of diabetes in general over the last 2 years, and there are many data arguing there is association between the coronavirus and diabetes. But we are waiting for more details about it. The second, yes, regarding in addition to diabetic DKA incidence increase with newly diagnosed diabetes. We have the DKA incidence more when the patient lost follow-up during corona season and the lockdown. So we have 2 reasons. I have patients with corona infection diabetic, but up to my experience, I found that they came with mild symptoms. I did not have a severe case. Yeah. Thank you.
I have a question.
Yeah.
Yes, please. You need microphone?
Thank you very much, Dr. Naila. I'm Dr. Shabib. I want to ask you if you have any information about the new single weekly shot of insulin, the trizipatide. Any information about pediatrics? I know there is a one running study started in March, but are you aware I'm sure you're aware of this more than I do, and I'm seeking for information from you.
Yeah. Thank you, Dr. Well, still I'm waiting for the final data because having to have a long-acting in for patients with type 1 very difficult, not like type 2. Type 2, they are produced, they can wait it for a 1-week shot. Usually we are dealing with more physiological need. For that, the daily is the best, but I'm waiting. I agree with you. There is a study, but not published yet. So I'm waiting for the final data. I have been for many years waiting for that, but still our patients in daily and 4 times a day.
This is one of our good news for the year. I mean, it's so nice to have a single shot a week rather than 7 shots a week for our diabetic patients, whether adults or pediatrics.
Thank you.
Thank you.
Okay, our next speaker is Dr. Abdullah Eliel. He's a pediatric nephrologist at the Children's Hospital of New Orleans in Louisiana, USA. He received his medical degree from the University of Jordan in Amman and completed residency training at the Children's Hospital of Michigan. He finished fellowship training at the Children's Hospital of Philadelphia. His interests include chronic kidney disease in children and optimization of electronic health record systems. He is going to speak about pediatric hypertension.
Today I will be talking about pediatric hypertension in 2 sessions. The first session will go over the diagnosis and evaluation of hypertension, and in the second session we'll talk about the management of hypertension in pediatrics. I have no financial disclosures related to this talk. The outline of my talk today, I will briefly go over the clinical significance of hypertension in children. We'll review the definition and diagnosis of hypertension. We'll also talk about the blood pressure measurement technique, and finally spend some time talking about the evaluation of children with hypertension. So starting off with the clinical significance of hypertension in children, this is a slide that shows the global prevalence of hypertension. This is from a meta-analysis that was recently published in JAMA in 2019, where they looked at 47 articles across the globe, and they reviewed the prevalence of hypertension from 1994 until 2018. And what they found was that the prevalence of hypertension has been increasing over the past 20 years or so. So the light blue line shows the prevalence of hypertension in the 2000s. The orange line is the 2010, and 2015 is the black line. And you can see that the prevalence of hypertension is increasing across all age groups, and that the prevalence of hypertension is the highest in children that are around 14 to 15 years old. As a general population, the prevalence of hypertension was roughly 4%, and it peaked at 7.5% in the 14-year-old age group. And when they broke this down by geography, by regions, the Middle East had very similar numbers. The prevalence of hypertension was roughly 3.5%, which gives you an idea regarding the scope of this problem. So why is hypertension important in children? Well, we're going to spend more time talking about that in the second lecture, but higher blood pressure in childhood is associated with higher blood pressure in adulthood. Also, hypertension in children is associated with intermediate markers of cardiovascular disease, such as left ventricular hypertrophy, and we know that is associated with significant cardiovascular outcomes in adults. And so there's reasonable evidence that we should take hypertension seriously in children to avoid severe consequences in adulthood. So moving on to the definition and diagnosis of hypertension, we have two main guidelines that have been released relatively recently. The first one is from the American Academy of Pediatrics. That was released in 2017. And the second one is from the European Society of Hypertension that was released in 2016. And while there are significant overlaps between the two guidelines, there are some differences which I will highlight as we move forward. But for the practical purposes of this presentation, I will be sharing most of the data from the more recent guidelines of the American Academy of Pediatrics. So in the AAP guidelines, they define a normal blood pressure based on the age groups, first of all. So children that are 13 years and above follow the adult blood pressure categories. And if they are less than 13 years of age, then they follow the percentiles. So normal blood pressure is considered if your blood pressure is less than the 90th percentile for both systolic and diastolic. It is considered elevated if it's between the 90th percentile and the 95th percentile for either systolic or diastolic. And stage 1, if it's between the 95th to 95th plus 12, which is an increase from the previous guidelines, the fourth report, where this was 5 millimeters. And stage 2 hypertension is blood pressures that are greater than or equal to the 95th plus 12 millimeters. Now, for those that are 13 years and above, the guidelines follow the same adult cutoffs. So normal blood pressure is less than 120/80, and elevated blood pressure is if the systolic is between 120 to 129, but the diastolic should still be less than 80. If you have elevated systolic more than 130 up to 139, and diastolic 80 to 89, that's considered stage 1 hypertension. And then stage 2 hypertension is greater than or equal to 140/90. So this is the blood pressure charts that we are all familiar with. And in the newest report for the AAP, they updated the chart. They looked using the same information and reference ranges from other reports. The only difference is they excluded the patients if they were overweight or obese, because that would be a confounding factor. And that led to a slight decrease in the blood pressure cutoffs for children. And for practical purposes, they also published a simple table that can be very practical and used in the clinic that for screening blood pressure values based on their age group. And you can see here, as the child gets older, the values are higher for both boys and girls until you reach the age of 13, where we use 120/80 for both boys and girls as the cutoff for defining elevated blood pressure. So ultimately, the diagnosis of hypertension based on the AAP guidelines is a blood pressure greater than the 95th percentile or more than or equal to 130/80 millimeters obtained on at least 3 separate visits. And on the next slide, we'll talk about the algorithm approach to having an abnormal blood pressure reading. So if the blood pressure is elevated above the 90th percentile, then the blood pressure should be repeated twice, and the average should be used. Now, initially, per the guidelines, it's okay to use auscultation or oscillation in terms of the device that is used. But if the blood pressure is persistently elevated in the office, then it should be confirmed via auscultation. And based on the blood pressure value, if the patient has elevated blood pressure, then they should undergo lifestyle counseling and have their blood pressure repeated in 6 months. If they have stage 1 hypertension, we go with lifestyle counseling and repeat the blood pressure in a few weeks. If they have severe hypertension, stage 2 hypertension, then they should be initiated on treatment. And we'll talk a little bit more about that in the second talk. So hypertension is one of those cases where a new high score is not a good thing. All right, so in the next few slides, I'd like to spend some time talking about the blood pressure measurement technique. And the reason is that the way the technique for the blood pressure measurement is obtained significantly affects the blood pressure readings and what you do based on that. And we don't, unfortunately, we do not have any other method, reliable methods that we can use consistently. So the two main methods to obtain the blood pressure measurement are auscultation and oscillation. And so just as a refresher, with auscultation, we inflate the cuff until you no longer feel the radial pulse, and then we listen at the brachial artery. The first sound that is heard is called the first Korsakoff sound, and that is the systolic blood pressure. And we listen until the sound disappears. That's the fifth Korsakoff sound, and that is considered the diastolic blood pressure. Whereas with oscillation, the device measures the vibrations from the arterial wall. And from the maximum vibrations, it measures the mean arterial pressure, and it calculates the systolic and diastolic blood pressure based on the mean arterial pressure. Now, the challenge with oscillation is that the way the machine measures the mean arterial pressure from the oscillation and the way that it calculates the systolic and diastolic blood pressure is proprietary. It is something that is that the companies do not share with each other. And so the different devices cannot be compared. And therefore, our reference has been and remains the auscultation method. And the normative data that we have is based on the auscultation method. And therefore, because oscillation is very practical, it is reasonable to start with checking the blood pressure using oscillation. But if it is abnormal, it should be confirmed with auscultation. So how should the blood pressure be measured? So there are a few factors that should be taken into account when you're checking the blood pressure. The patient should be seated in a quiet room, the back supported, feet uncrossed, flat on the ground. In our clinic, if the child is short, then we will use a small stool or small chair to put that underneath their legs and support their feet. The blood pressure should be measured in the right arm. The right arm should be at the heart level, so it should not be too high or too low compared to the heart level. It should be supported and uncovered above the cuff. In terms of the cuff size, in an ideal situation, the arm circumference should be measured, and the bladder inside the cuff, the length should be 80% of the arm circumference, and the width should be 40% of the arm circumference. Now, this is not very practical in the clinic. So a lot of times when we are trying to choose the right cuff, we will make sure that it at least covers the majority of the arm from the acromion to the olecranon, and that the cuff fits well on the arm, does not pop off as it inflates. And then when we're auscultating, the cuff should be inflated 20 to 30 millimeters above the point where the radial pulse disappears, and the measurement should be 2 to 3 centimeters above the antecubital fossa. And the patient should be able to flex at the elbow while they're wearing the cuff. So ambulatory blood pressure monitor is another option that is sometimes available to check the blood pressure. It is a machine that is worn by the patient and checks their blood pressure every 20 to 30 minutes over a 24-hour period. And it is used in children that are 5 years at least 5 years of age and older so that they can be compliant and willing to wear the machine for 24 hours. It is considered the gold standard for measuring blood pressure, but it is not readily available at all offices, doctors' offices, and institutions. And it is labor intensive to get the device, to get the study done. It is used to diagnose white coat hypertension, where the blood pressure is high at the doctor's office and normal at home. And it is helpful in managing masked hypertension, where the blood pressure is normal at the doctor's office and elevated at home. So this is just a picture that shows you what the device looks like. The patient wears the cuff on their arm. It's connected to a device the size of a cell phone, and they carry it for 24 hours. And this is just a picture of what the machine looks like. And we get readings that look something like this, where the white area is the time that the patient's awake, and the shaded area is the time where the patient is asleep. And the top and bottom horizontal lines are systolic and diastolic blood pressure readings. This is an example of a patient with white coat hypertension. So the blood pressure in the office was 140/85. However, when we did the 24-hour blood pressure test, the majority of the readings were normal at home. And so the patient would be diagnosed with white coat hypertension. And this is an example of masked hypertension. So the patient had a normal blood pressure reading in the office. When we checked the blood pressure readings at home, they were significantly elevated for the majority of times when the patient was awake and asleep at home. What about at-home measurements? So at-home measurements refers to sending the patient with a blood pressure device to check their readings at home and get an idea of what the readings are based on what the patient reports. Now, there has been some interest in that because of the practicality of doing that. However, there are some challenges that are unique to children. One of them is there's a lack of devices that can be reliably used for children. There are only few devices that have been validated in children. So the recommendations are to not use these machines to diagnose hypertension, but they can be helpful in management. So if you have established that the patient has hypertension, they're on treatment, then the readings at home can be helpful, can help guide management and give you an idea of what the blood pressure readings are at home. There are newer devices on the market now. I'm not sure if they're available in Bahrain and in the region, but they are devices that measure the blood pressure at the wrist. They're convenient, they're reproducible. You get fairly consistent readings from these, but they have not been validated in children, and there's a lack of normative data for these devices. So their use is currently not recommended in the diagnosis nor the management of hypertension. But stay tuned, this may change in the future. And so I'd like to spend the remaining time talking about the evaluation of patients with hypertension. And so when we think of evaluation of hypertension in terms of etiology, the classic teaching is looking for primary versus secondary hypertension. And whereas primary hypertension is very common in adults, it tends to be less common in children, especially the younger they are in age. And so in infants, secondary hypertension is almost always the cause. It is the most common cause of hypertension. The common reasons are coarctation of the aorta, renovascular, including renal artery stenosis, and renal parenchymal. So patients that have congenital abnormalities of the kidney and chronic kidney disease tend to be the majority of causes of hypertension in infants. Secondary hypertension is still the most common cause in school-age children, especially those that are under 10 years of age. But once they get into the teenage years, that's when the situation is generally flipped, and their primary hypertension is the most common cause. Secondary hypertension tends to be less common in that age group. And so for primary hypertension, there's been a well-established association of obesity and hypertension leading to primary hypertension. So we know that obesity and obesity-related comorbidities are on the rise. So in this graph, you can see that worldwide, the prevalence of obesity has increased in both adults and in children, and that's associated with an increase in type 2 diabetes, metabolic syndrome, and hypertension. And so obese children have a 2 to 4 times increased risk of hypertension. And so you can see on this graph on the right, there's in 70 patients with primary hypertension, you can see the distribution of the BMI. Much larger proportion of patients had elevated BMI in this retrospective study. And the typical characteristics of children with primary hypertension is that they are overweight or obese. They tend to be older in age, so more than 6 years old, and there tends to be a positive family history of hypertension. And so those should be kind of the clues that give you an idea that the patient likely has primary hypertension as opposed to secondary hypertension. So what about secondary hypertension? So there's a long list of causes of secondary hypertension that is beyond the scope of this talk. That can be a talk on of its own. But the common groups to consider when you're thinking of secondary hypertension is renal causes, cardiovascular causes, neurological causes, endocrine, and then medications or toxicologic. So renal causes, common etiologies such as glomerulonephritis, patients with obstructive uropathy, patients that have renal failure, acute or chronic kidney disease, patients with renovascular disease, so renal artery stenosis. Cardiovascular, specifically coarctation of the aorta, tends to be common in the younger children, so it's a cause to think about. And then patients with increased intracranial pressure or trauma can be some of the neurological causes of hypertension. And then for endocrine causes, there are numerous causes or things to think about, but specifically thyroid disease, hyper and hypothyroidism can cause hypertension. Hypercortisol states, adrenal dysfunction are all associated with secondary causes of hypertension. And then always remember to look at the patient's medication lists and ask about that. So patients that are on oral contraceptives, patients that are on steroids, patients that are receiving stimulants, so those are the patients that are diagnosed with ADHD, and certain medications like cyclosporin, tacrolimus, or in the Middle East, it's common. Some people might like araqsus. So licorice or araqsus can cause hypertension as well. So these are important clues that can be helpful to think about when you're looking for secondary causes of hypertension. So the goals of evaluation in a patient who has hypertension in children are mainly two goals. One is you want to rule out secondary causes of hypertension. And number two, you want to assess for end organ damage in patients that have hypertension. And the history and physical exam are going to be extremely helpful in guiding you in terms of what to do for the workup. So the AAP guidelines recommend obtaining a urinalysis for all patients, chemistry panel and kidney function, getting a lipid profile, and checking an ultrasound for most patients. If they are obese or it's an adolescent, then also obtaining an A1C, looking at AST and ALT. So these help assess for metabolic syndrome. And then based on your history and physical exam, consider checking the thyroid function, getting a sleep study to assess for obstructive sleep apnea, and a CBC. And so these are, again, guideline recommendations. Obviously, your history and physical exam are going to guide what you need to do for your patient. So Echocardiography helps assess the left ventricular organ damage due to hypertension, and we can look at the structure and the function of the heart. So we look at any structural damage by assessing for left ventricular hypertrophy, and the function of the heart by assessing the ejection fraction. There are measurements and cutoffs that are used in children based on their age to assess the left ventricular mass, and an ejection fraction less than 53% is considered abnormal. So per the guidelines, echo should be done when you're considering starting medications, and repeated every 6 to 12 months if the echo is abnormal or the patient has uncontrolled hypertension. EKG is no longer recommended to assess LVH, so we do not obtain an EKG on a routine basis due to the low sensitivity for EKG in the diagnosis of LVH. So what about imaging? We obtain imaging in younger children and in children with an abnormal urinalysis or creatinine. So if there's a suspicion that the patient may have a renal etiology for their hypertension, renal imaging can be helpful. The Doppler renal ultrasound to assess for renal artery stenosis has about a 50% sensitivity. And the best results are in older children that are non-obese. So if you have a high index of suspicion that the patient may have renal artery stenosis, it's an older patient that can comply with and cooperate with the ultrasonographer, then you can obtain a renal Doppler ultrasound. And CT angiography and abdominal MRI are useful to rule out renal artery stenosis. If you have a high index of suspicion, angiography is the gold standard, but these are additional imaging that you can obtain if you really suspect the patient has renal artery stenosis. And this is an example where you can see there's significant tapering of the renal artery bilaterally, but it's more obvious on the right side. So in summary, hypertension is a rising problem in children. Diagnosis of hypertension requires a blood pressure that is greater than the 95th percentile if they're younger than 13 years of age, or more than 130/80 obtained on at least 3 separate visits. Blood pressure measurement technique is very important and obviously time consuming. So it requires patience. And evaluation depends on the likelihood of secondary hypertension based on the patient's age, symptoms, and risk factors. Thank you very much.
We will continue with the second lecture of Dr. Abdullah.
Hello and welcome to the second part of my talk, where we'll be going over the management of pediatric hypertension. So I have no disclosures. So the outline for this part of the talk will be going over the rationale for treatment of hypertension, the general approach to management, some more details on the lifestyle modifications for blood pressure control and pharmacological therapy. So as promised, some more on the rationale for treatment. So why treat hypertension in children? So there is no direct evidence that treatment of hypertension in children decreases cardiovascular disease in children on the long run. The main challenge in pediatrics is the low incidence of cardiovascular disease in youth. So you're unlikely to see myocardial infarction and stroke in children, and there's a long time interval that is needed to see these. So it makes it very difficult to follow up these patients for studies. But there's strong evidence that treatment of hypertension in adults decreases the cardiovascular disease. And there's also indirect evidence that treatment of hypertension in children decreases the risk of atherosclerosis and cardiovascular disease in adulthood. And I'm going to show you some of that evidence. So hypertensive children become hypertensive adults. And that has been shown consistently, and there's good evidence to support that. An example of this is the study that was published in 2011 on 4,300 children in Finland that were followed up for at least 27 years. This started in the 1980s, and they followed them up. And what they found was that children with, you can see that children that had hypertension continued to have hypertension at an older age, in addition to other risk factors. So childhood blood pressure, lipid, and body mass index strongly correlated with the values that were measured in middle age. Also, childhood hypertension was associated with increase in cardiovascular disease in adults. So this comes from a systemic review that was published fairly recently, where they looked at 19 articles and completed a meta-analysis, and they showed that the intermediate markers of cardiovascular disease were high in adults, were abnormal in children that had elevated blood pressure. And so intermediate markers that are typically used are left ventricular hypertrophy, increased carotid intima media thickness, and increased pulse wave velocity. And in those patients, there was an increased odds ratio of having an abnormal intermediate marker if they had elevated blood pressures in childhood. And this is just a table to show what has been strongly established in adults, which is higher blood pressure is associated with a significantly increased coronary heart disease or stroke in adults. That is incremental by age and by blood pressure, both systolic and diastolic. Hypertension also leads to chronic kidney disease progression, and strict blood pressure control slows the progression of chronic kidney disease. This was beautifully demonstrated in the ESCAPE trial, which is now a little over 10 years old, but they randomized 385 children with chronic kidney disease to strict blood pressure control versus conventional blood pressure control. So the strict blood pressure control, they targeted a blood pressure less than the 50th percentile, whereas in the conventional, they targeted 50 to 90th percentile. And they followed these patients over 5 years, and what they found was over those 5 years, those with intensified blood pressure control had substantial benefit over conventional blood pressure control, where a larger number of patients with conventional blood pressure control ended up with significant progression of chronic kidney disease or ended up with renal failure. All right, so moving on to the approach to management. And in this part, I'm going to focus more on the non-emergent treatment of hypertension and mainly the treatment of hypertension in children, not in infants. So the target blood pressure goals per the AAP guidelines, the 2017 guidelines, as I mentioned earlier, is a blood pressure less than the 90th percentile if they're less than 13 years of age, or less than 130/80 if they're 13 years or older. And in chronic kidney disease, we target a lower blood pressure, less than the 50th percentile based on ESCAPE trials. This is one of the areas where there's a significant difference compared to the European guidelines, where they generally recommend a blood pressure less than the 95th percentile instead of the 90th. And in this group, they also include diabetes, so CKD and diabetes, but they differentiate if they have proteinuria or no proteinuria. So if the patient has CKD and proteinuria, target a blood pressure less than the 50th percentile. If they have CKD or diabetes and no proteinuria, then we target blood pressure at the 75th percentile. Again, this is expert opinion. So either generally we know that lower is better, but we don't have evidence to support a specific cutoff in children. All right. So our general approach involves two strategies for blood pressure management. The first is lifestyle modification, and the second is pharmacological therapy. So with lifestyle modification, this is indicated in patients that have elevated blood pressure or asymptomatic hypertension, stage 1 hypertension, without end organ damage. Pharmacological therapy is indicated if the patient has symptomatic hypertension, evidence of end organ damage, stage 2 hypertension, or if they have chronic kidney disease or diabetes, because we know that these patients are at risk for progressive kidney disease. And with pharmacological therapy, lifestyle modification should be continued in these patients, so they are not mutually exclusive. This is a slide that we had gone over earlier, but just a reminder that if the blood pressure is above the 90th percentile, it should be confirmed. And if it was obtained using an oscillometric device, it should be confirmed via auscultation. And based on the value, if the patient has an elevated blood pressure, then the recommendation is to proceed with lifestyle counseling and repeat the blood pressure in 6 months. If the patient has stage 1 hypertension, we start with lifestyle counseling and have them come back in 1 to 2 weeks to check the blood pressure. And with severe hypertension, stage 2 hypertension, then evaluation should be initiated, and we should start with treatment, which might include a trip to the emergency room if they have symptomatic hypertension. So what about sports participation? Is that allowed in patients with hypertension? So patients with hypertension can and should participate in competitive sports after they complete an evaluation. If the blood pressure is below stage 2, then they are allowed to participate in all sports, including competitive sports. Based on the American Heart Academy and the American Cardiology, the ACC 2015 recommendations, athletes with left ventricular hypertrophy should limit their participation until the blood pressure is normalized. And if they have stage 2 hypertension, they should be restricted from high static sports, such as weightlifting, boxing, and wrestling, until the hypertension is controlled. So in those situations, if the patient has severe hypertension or has LVH, they should limit their participation until they are treated and the blood pressure is under control. But then there should be no restrictions after that. All right, so let's dive a little deeper into the lifestyle modifications for blood pressure control. So there's evidence that lifestyle changes lead to a decrease in blood pressure and potential resolution of elevated blood pressure. And there's more robust evidence in adults compared to pediatrics. So this table comes from the ACC AHA guidelines, hypertension guidelines in adults that were released in 2017, where they looked at the available literature and pooled the effect of the different interventions on the impact on the systolic blood pressure, whether the patient was hypertensive or normotensive. And so weight loss has about a 5 millimeter mercury impact in patients with hypertension. The best goal is an ideal body weight, but aim for at least a 1 kilogram reduction in adults, which might be a little bit different in children. Healthy diet, specifically the DASH diet, impacts the blood pressure with about 11 millimeters of mercury, reduced intake of sodium, ideally less than 1,500 milligrams per day, has a 5 to 6 millimeter impact on the blood pressure, and increased intake of potassium impacts the systolic blood pressure by 4 to 5 millimeters. Physical activity also has an impact on blood pressure, so that includes aerobic and non-aerobic physical activity, and that also impacts the blood pressure roughly on average 4 to 5 millimeters of mercury. So in our clinical practice, we try to focus on diet changes, physical activity, and weight loss, since they seem to have the largest impact on blood pressure in adults. And there's some evidence in children that supports that. So starting with the dietary changes, the DASH diet has been strongly recommended in patients with hypertension. This is the dietary approach to stop hypertension, was introduced in 1997. And the key components are essentially increase the intake of fruits and vegetables, whole grains, lean protein like fish and red meat, and decrease the intake of sugar, sodium, and saturated fats. And the studies have consistently shown that this diet helps decrease hypertension. So an example of this in pediatrics was a study in almost 2,200 girls that were followed up for more than 10 years until they were at the age of 18 to 20. And they had them complete a 3-day dietary record on 8 different cycles. And they assessed their daily intake of fruits and vegetables and their daily intake of dairy products. And what they found was girls who consumed at least 2 servings of dairy products and 3 servings of fruits and vegetables in their early to mid-adolescent year had a 36% lower risk of elevated blood pressure in late adolescence. And you can see that here, and that's the difference between the boxes that you see on the top and the triangles that you see on the bottom. They had a lower blood pressure by increasing their intake of dairy products and fruits and vegetables. What about sodium intake and hypertension? So that has also been consistently shown to decrease salt intake has been consistently shown to have an impact on the blood pressure. This is a study that was published in 2012 where the patients completed a dietary recall in approximately 6,000 subjects that participated in the NHANES study. The children were 8 to 18 years old, and what they found was that the average intake in this population was 3,400 milligrams of sodium per day, which is 1.5 to 2 times the recommended intake. And as you can see from the graph here, with increased sodium intake, there was an increase in the average systolic blood pressure. And the highest group that had the most sodium intake had the highest blood pressure. And the difference was more pronounced in the children that were obese or overweight, as you can see here in the black bars, compared to those that were non-obese or non-overweight in the gray bars, which also held true as they had increased sodium intake. And in this study, they found that each 1,000 milligram per day of sodium intake was associated with a 1 millimeter increase in the systolic blood pressure. So in this situation, Salt Bae is not recommended. All right, what about physical activity? So in the AAP guidelines recommend moderate to vigorous physical activity at least 3 to 5 days per week, 30 to 60 minutes per session. There's some data in children that increased physical activity leads to a lower blood pressure. So there was a recent meta-analysis that included all studies which involved physical activity for at least 1 year. And they found that that increased physical activity leads to a lower blood pressure, on average 1.5 to 2 millimeters of mercury, and that the combined diet and physical activity led to a greater reduction in the blood pressure, more than diet or activity alone. So it seems like a combined effect of diet and physical activity is most helpful for blood pressure control. This is another example that looked at physical activity where they randomized 44 obese children to exercise 60 minutes 3 times a week versus controls that did not participate in the exercise. And they looked at the blood pressure after 3 months, and they found that there was a significant decrease in the blood pressure in those children that participated in the exercise. So it seems that physical activity plays an important role in decreasing blood pressure as well. So weight loss, there's less evidence of that in children, but it is known that the combination of decreased caloric intake and increased physical activity will help with your, will lead to weight loss and help with the blood pressure. In adults, there seems to be a dose-response relationship where it looks like about 1 millimeter, a decrease of 1 millimeter per kilo of weight loss. If the patient loses 1 kilogram as an adult, their blood pressure is probably going to drop by 1 millimeter of mercury. And as I'm sure many of the listeners in the audience are aware that it is quite challenging to lose weight as a child or an adult. And a multidisciplinary approach can be helpful. So consider endocrine consultation, evaluation by a nutritionist, and some techniques that might help with weight loss, such as motivational interviewing, pharmacotherapy, and in more severe cases, bariatric procedures. Right. So moving on to the pharmacological therapy, general approach to pharmacotherapy, we recommend choosing a medication that achieves the desired effect with the least side effects. So we usually start with a dose that is on the lower end for the medication and slowly increase every 2 to 4 weeks until we reach the maximum dose or the patient has side effects and is not tolerating the medication. If they still don't achieve their target blood pressure, in that situation, we add a second drug from a different class, again, starting on the lower end and increasing incrementally until we reach the maximum dose or the patient becomes symptomatic. And same situation, if we don't reach the target blood pressure, then we add a third medication and a fourth medication. There's no evidence-based recommendation on the initial drug of choice in children, but as a general principle, we start with a medication class that potentially targets an underlying etiology for hypertension if one is present. If an added bonus, the medication has an additional benefit to the patient, then we like to start with that. Or if the medication avoids specific side effects. And I have a few slides on that coming up. This is probably my favorite slide that summarizes all the medications that are used in hypertension, the ABCDs. And so A stands for ACE or ARBs and alpha-2 agonists. B stands for beta blockers, C stands for calcium channel blockers, and D for diuretics. So if you're considering starting a medication for a patient, it's good to think about the ABCDs and think about which one of these classes has a favorable side effect or has a contraindication that I need to avoid, and it can help you decide which group to use of these medications. So a little bit more about these medications. ACEs and ARBs, they're medications, examples of the angiotensin converting enzyme inhibitors are medications that end with pril. So enalapril and lisinopril are common examples. And angiotensin receptor blockers usually end with sartan, like losartan and valsartan. The ACEs and ARB therapy are very helpful in unilateral renal artery stenosis because there's increased renin secretion and activation of the renin-angiotensin-aldosterone system. They should not be used, or they can be used with severe caution in patients with bilateral renal artery stenosis. Also, these medications have an anti-proteinuria effect. And we know that proteinuria leads to progression of CKD, so they're commonly used in patients with chronic kidney disease and diabetic nephropathy. Main side effects, cough, headache. They can lead to acute kidney injury and hyperkalemia, so the labs need to be monitored when the patients are on these medications. They are contraindicated in patients with angioedema and absolutely contraindicated in pregnancy. I am hoping we don't see or have any pregnant children, but it is a medication to be aware of. It is toxic to the fetus. The second group are the beta blockers. So examples of non-selective beta blockers are labetalol and beta-1 selective blockers like atenolol. Favorable use would be pheochromocytoma, but they should only be used after alpha blockade in those patients. and they might be helpful in patients that have anxiety or tachycardia because of the side effect of bradycardia that these medications have. They also have impaired glucose. They lead to impaired glucose tolerance. They're contraindicated in patients with asthma, and they should be used in caution in patients with heart failure. And they have a modest effect on blood pressure, but they are not recommended as a first-line treatment in adults nor in children. Calcium channel blockers, I call these the neighborhood-friendly medications. They're medications that have no absolute indications, but they also have a very favorable side effect profile. So they're good medications to start if you're not sure why the patient has hypertension or the family is concerned about starting a medication. Calcium channel blockers tend to be a very good medication to start with. Examples include amlodipine and nifedipine. Major side effects are flushing and peripheral edema, rarely significant enough to stop the medication. And there's no significant contraindication to these medications. And last but not least are diuretics. The two main classes of diuretics that are used for management of hypertension are loop diuretics and thiazide diuretics. So loop diuretics like furosemide, thiazide diuretics like hydrochlorothiazide. Loop diuretics are not used as a first-line agent. They can be used as an adjunctive therapy. Sometimes in patients with heart failure, that may be kind of the major benefit. Thiazide diuretics are actually favorable as a second-line agent, especially in patients that have salt and water retention or poor dietary habits and increased sodium intake. Thiazide diuretics tend to be the favorite second-line agent to start with. The main side effects is they can cause electrolyte disturbances, so it's good to be familiar with the nuances of those. Hypokalemia tends to be a major one for both loop and thiazide diuretics, and thiazide diuretics can increase the uric acid. They're really not beneficial in patients that have anuria. Right, so when should I stop therapy? So there's no, again, this is an area where there's no evidence-based recommendations, but in general, recommend that the patients be followed every 3 to 6 months when they are on a stable dose. Gradually decrease the dose of the medication if they have a normal blood pressure or low normal blood pressure. And if the medication ends up being stopped, and continue to monitor the blood pressure and see how the patient does. If they have a secondary cause of hypertension, then typically treating the secondary cause will help their blood pressure. For primary hypertension, it really is more about focusing on the lifestyle modifications that addressing the risk factors for those patients. So in summary, the treatment of hypertension in children is recommended based on indirect evidence of long-term risk of cardiovascular disease. Lifestyle modifications should be implemented in all patients. Pharmacotherapy is recommended if the patient has symptomatic hypertension, evidence of end organ damage, and in patients with chronic kidney disease or diabetes. And choice of medication, dosing, and follow-up should be tailored based on the patient. And thank you.
Thank you, Doctor. Very informative presentations. Any questions from the audience? The chat? I have 2 questions for you. First of all, regarding the blood pressure measurement, can we measure it on the right and the left arm? Does it matter?
Yes, hi. So for the site of the blood, can you hear me okay?
Yes.
Yes.
So for the arm measurement, the classic recommendation is to check it in the right arm. And the reason is to avoid, there are some patients that may have coarctation of the aorta in the arch and have low blood pressure in the left arm, but actually are hypertensive if you check it in the right arm. So in general, it's good practice to check the blood pressure in the right arm consistently, unless the patient has had an echo where you have ruled out coarctation of the aorta. So that's generally our approach. So if a patient is known to have no coarctation, then either arm should be okay.
Great, thank you. And the next question is regarding the fitness bracelets that are very common now. Do you recommend them in children to check their heart rate? And is the heart rate an abnormal heart rate in children an indication that maybe their blood pressure is not normal?
Yeah, yes, thank you for this very interesting question. So I think we're still learning more how to use these, fitness bracelets or step trackers that adults and children use. The way they've come to market is tech companies have developed them, and now we're stuck with trying to, see their benefit or how we can use them. I would say, from a practical standpoint, they can be helpful to encourage a patient to exercise regularly, meet certain goals. I'm not aware of conditions where they have been used to, to diagnose hypertension or monitor heart rate in the diagnosis of hypertension.
Thank you. Okay, now we have our last speaker, Dr. Mohammed Salman. He is a pediatric specialist and owner of Al-Janan Medical Center. He is the director of Medical Education and Education Plus and the founder of Right Path Consultancy. He will be speaking today about common neonatal problems.
Scientific committee for inviting me to give this presentation. Actually, I'm part from the organizing committee, but it's my pleasure to be involved as a speaker in this eminent conference. This year we are in the second MACH conference, and the first one was very successful event, and today we are reaching to the end. I know I am the last speaker, and the time today is Friday and after lunch, so I hope all the audience is not going in the sleeping mood and they are still alert to learn from us and to hear and to interact also with us. The getting baby is an excitement and excited moment for the mother and the family. And from the time the mother getting the baby between their hand, she starts seeing the concern and worry about her baby. And actually, my lecture is built on a dialogue between me and one of my patients when she come for a visit after getting her first baby. And I found she have a lot of concern and question about a lot of things that she discovered in her baby. And most of my answer to her, this is a normal phenomenon, and this is a common problem. This is not needed treatment. So she starts asking questions about why all these things in my baby. And from that time, I'm writing on small articles in Arabic, and was one for the newspaper and just to educate the mothers about these common neonatal problems that she can see, and it is not harmful, and it is a normal phenomenon. It will disappear within the time. And from that time, I'm starting putting this lecture to presenting for all general pediatrician and the GB to know how to deal with these common neonatal problems. So what are we looking for in this presentation? And I would like to ask also our audience from the Zoom to write from their experience, what are the common neonatal problems they are seeing in their practice? If they can share on their chat box, what is the most common things that they are seeing during their daily practice, and we will back to see how it is often and common they are seeing the same problem from the mothers or in the neonate. Today I will go through the healthy newborn and what are the type of classification that used to classify these common problems in a newborn. And then we will go through the common minor newborn problems and conditions. I'm not calling disease because most of them are just a conditional and it will be disappear during the time. And then we will go through the birth trauma and injuries. The transition from intrauterine to extrauterine life is a complex process involving almost every system in the body. The most dramatic change are seen in the lung and the cardiovascular system, and failure to sufficiently make this transition can be life-threatening, and these infants often require urgent supportive care. It is essential to recognize the general appearance and vital sign of the normal newborn baby. So how does the healthy newborn look like? He looks dark, purple or red in color, symmetric, vigorously crying, and flexed extremities, which is a sign of a good muscle tone. And almost hands are tightly fisted with thumb covered by the fingers. The healthy newborn, the first 24 hours of life is a very significant and a highly sensitive time due to critical transition from intrauterine to extrauterine life. So it is important to assess the baby. And the most common score that we are using to assess the baby in the first minute and then after 5 minutes, and sometimes we are going to up to 10 minutes, is the Abgar Score. And the Abgar Score is developed by Dr. Virginia Abgar in 1952. She was an anesthesiologist at Columbia University, and she is the one who developed the Abgar Score. The score is an rapid process and is easy to be used to assess the infant, the newborn after delivery, and is depend on 5 major criteria: is the heart rate, the respiration, muscle tone, reflex and irritability, and skin color. And the score is divided between 0 and 2. If the child have heart rate absent or below 100, so the score is at 0 to 1. If it is above 100, the score will be 2. Again, for the respiration, if there is no any respiration, 0. Weak or irregular, the score will be 1. And if the child is crying, strongly crying, then the score will be 2. Muscle tone, either absent or there is some reflection or active movement. The reflex, either no response to stimulus or there is feeble crying when stimulated, or there is sneezing, coughing, both away when stimulated. And the skin color, the normal color, as we say, it is pink to red. But if there is just bluish on the extremities, this is the score will be 1. If the whole body is pale or blue, then the score will be 0. And then we will sum of all the scores, and according to the accumulation of the degree, then we will manage the child. The normal vital sign, this is very important to know about all these normal vital signs. And the common newborn problem is always classified into different classification. There is no standard classification for the newborn problem. It can be classified according to the systemic classification, where it will be classified by system: respiratory, cardiovascular, GI or skin, genitalia, head and neck, renal or neuro. Or sometimes it is classified according to the etiological classification. If it is a birth trauma and injury, or it is physiological or pathological cause, infectious, maternal-related condition, and in certain situations it's also classified according to the severity, where it is an urgent, harmful, or non-harmful. Now I will go through the common minor problem in the newborn babies, and in the first session, our doctors will also go through a lot of problems in the skin and the other manifestation of the problem in infant and children. The first thing that the mother is noticed when we are giving the baby to the mother or after delivery is this whitish adherent cheesy-like covering a newborn skin. And even it is normal for the doctors, but for a mother who's receiving the first baby and she just holding the baby, this is something which is worried her and she don't know about it. So we need to clearly identify this vernix caseosa to the mother, which is produced by the epithelial cell breakdown. And it is very important, by the way, for the passage of the baby safely through the birth canal, and it's also prevent the transepidermal water loss. It's helpful to maintain the body temperature and protect the delicate skin from amniotic fluid, and as it works as a barrier to bacteria. In postterm, we didn't see this vernix, and removing for vernix as for cosmetic reason is not recommended. We can keep it because it is unimportant. The second one is the acrocyanosis, or what we call peripheral cyanosis. It is a bluish discoloration of hands, feet, and perioral area. Particularly, the palm and soles are blue, the skin and mucosa are bare, due to immature peripheral circulation. The cause of this acrocyanosis is because of immature peripheral circulation, and it can be exacerbated by cold temperature. It's almost disappearing over the next few hours. It's important to differentiate this from the hemodynamic instability or central cyanosis, which is sometimes caused by cardiovascular disease or congenital heart disease. Plethora. It is also very common, and we are seeing this in many infants, and it is that you can see the differentiation between the normal color and the deep rosy red color, and more common with the polycythemic baby, but can be seen in an over-oxygenated and overheated infant. And in this situation, it is very important when we are receiving the baby and we're starting the resuscitation sometime, we are, during the practice, we over-oxygenate the baby, or the warmer is very high, and this overheated can lead to plethora. Again, it is a normal phenomenon and lasts for only several hours. The facial bruising. It is more common when there is a tight nuchal cord, and when the delivery is precipitous or difficult, or when the infant is bundled. This facial appearance could be mistaken for cyanosis, but with a quick comparison to the color of the rest of the body, the diagnosis will be very clear. And this type of bruising resolves over the courses of several days. Common that we are seeing is the caput succedaneum, and this is almost after the normal delivery, and it is just a diffuse edematous swelling of the soft tissue of the skull that may extend across the suture line, and this is very important feature to differentiate from the other swelling. It is secondary to the pressure of the uterus or vaginal wall on areas of the fetal head, bordering the caput. Usually it is again resolved within several days. And this is, I saw a lot of the babies when they came for the post-natal visit, they asking about this swelling, and they want why this child have this swelling, and this is just we need to clearly explain the cause of this one, and it is a normal phenomenon. It will be disappear soon within several days. This is very important to differentiate between the cephalohematoma and the caput. The cephalohematoma is an accumulation of blood under the skull that never extend across the suture line, and this is how we can differentiate. And it can be secondary to a traumatic delivery or forceps delivery. Most cephalohematoma resolve in 2 to 3 weeks, and again, it is not harmful to the baby, and just need careful monitoring. There is no need for aspiration of the hematoma in many cases. Only in certain rare cases we may need to the aspiration. And it's not affect the brain, by the way. There's a lot of birthmarks that we see, and one of the common birthmark is the Mongolian spot, and this is also resolved within few months after birth. Another common birthmark is the angel kisses, and this is an a reddish or pink area on the forehead, upper eyelid, and the bridge of the nose and the back of the neck. And this is very common. A lot of mothers are come and asking about this angel kissing, and they want to, is this will be permanent, how it will be disappear, did we need to use any treatment? And usually it is disappear within first few years, sometimes second years is disappear, and it's not need any treatment. Common problem that we see after delivery is the eye edema. And most infants exhibit some degree of eyelid edema after birth. And this puffiness sometimes prevents the pediatrician or the midwife from the examination of the eye. But carefully opening the eye and examining the eye is very important. And edema is resolved after the first few days of life. The nether teeth. This is even it's rare, but we saw this in our practice. And again, it is something which is worried the mother and the family, why the child are born with teeth. What is this teeth? What is the future? It will affect him. So those infants who are born with this teeth, we need to identify if it is an primary teeth or it is an extra teeth. Actually, the primary teeth are firmly attached and should not be removed unless it is attached by a thread of tissue. And that time being, we afraid from keeping this nether teeth because it may be swallowed. And we need to take the advice of the pediatric dentist to remove these teeth. The epicene bird is a small papule seen in the midline of the palate. It represents epithelial tissue that become strapped during the palatal fusion. It is very common and benign finding. One of the common neonatal problems that we are seeing in our practice is ear tag, which is on a single small ear. Tag is occasionally finding on physical examination, and it is often inherited as a familial trait. And when we found this ear tag, we need to examine the renal system. It is very important because there is a relation of the congenital malformation with the ear tag. So ultrasound is important to identify if there is any renal problem, renal congenital problem. Ear tag is also not easy to remove, but in the future, if the family would like to do surgery to remove this one for the cosmetic, yes, they can do. Tongue tie, many infants have a web of mucous membrane under the tongue that continues to the tip. As a result, the infant is not able to stick the tongue out, and therefore is said to have a tongue tie. This does not interfere with sucking and usually corrects itself with time. Nowadays, sometimes if we are finding this ties affect the baby to the feeding, which is not common, but in certain situation or because of the concern of the family, we refer this patient to the pediatric surgeon to cut and remove the tongue tie, and it is a simple procedure done in outpatient clinic with no any complication. Again, subconjunctival hemorrhage. Newborn often have small bilateral hemorrhage simply from the pressure of the uterine contraction, but it is more common after a traumatic delivery. The blood gets reabsorbed after a few days without leaving any pigmentation. It's not need to use any medication or treatment. It is just done because of the pressure and will be resolved spontaneously. The sticky eye, It's always common during the first few days, and it can be just cleaning with cotton swabs soaked in saline water, more than sufficient, and there is no need to use any medication. If there is an yellowish discharge, we can re-examine the baby because it may be secondary bacterial infection, like conjunctivitis. There is two types of conjunctivitis, septic conjunctivitis, and it's becoming less common during these days because in the past the practice is to use silver nitrate solution administered for prophylaxis of bacterial conjunctivitis, and as we stop this practice, we are not seeing this type of conjunctivitis. Septic conjunctivitis are most common and can be caused by chlamydia. It's almost common during the getting the infection while the baby is passing through the birth canal. One of the common problem that we see in the practice when the family bring the baby, male or female, and they notice that the baby have an enlarged breast, and in certain situations the breast is also secreting milk, and this is due to maternal estrogen. And the most important recommendation to our advice to the family that no need to squeeze and getting the milk out because this may lead to the infection and it's also painful. This squeezing may induce inflammation and the infection in the future. So it's just to keep it as is, and with time it will be solved by itself. Vaginal discharge. Many female infants have a white mucous vaginal discharge at birth, which may continue for a few weeks. Less commonly, discharges also may contain blood, and both, if it is with the blood or without blood, are normal, and will be solved by itself within a few days. Blocked nose. The neonate have a very small size of nose, and this because the child is also cannot blow, so he cannot clean the air passage, and this is why the child have an staphyno. Always it's not need treatment, but if it is affecting the feeding or the steaming, then using a normal saline or the cleaning the nose is essential to keep the child sleeping well and also feeding well. Umbilical hernia. Commonly develop a small umbilical hernia after the cord has been separated. This does not cause any problem and usually disappear without treatment when the infant starts to walk. If the hernia is still present at the age of 5 years, the child should be referred for possible surgical correction. It's not a harmful problem, and we can leave it unless it is big or it is affecting the baby. Then it's better to refer to the pediatric surgeon to correct it. Embellical granuloma. This is a small growth of tissue that forms in the belly button during the first few days, 2 weeks after the umbilical cord is cut. Embellical granuloma looks like a little red lump and may be covered in yellow or clear discharge. The umbilical granuloma may not bother the baby, however, it can become infected. This can lead to other symptoms such as skin irritation around the belly and a fever also. So almost we are seeing the baby with umbilical granuloma, and according to the size, if there is discharge or there is no discharge, we are providing the treatment. The treatment can be just applying the silver nitrate over this one, and it's just one time and finish. Sometimes the baby is back again and still the granuloma there, so we need to apply another dose of the silver nitrate. And in certain situation, we may need to refer this to the pediatric surgeon, and they can, by the thread or cutting the umbilical granuloma to remove it to avoid any irritation and infection. Jaundice, one of the more common symptom that we are seeing in the newborn. More than 75% of babies develop yellowish discoloration, but most of the cause are physiological. Only there is certain pathological condition. Almost the pathological condition develop in the first day of life, while the physiological develop in the second and third life. It can be stay from a week to a month, and if it is physiological, it is important to just reassure the family and continue the breastfeeding, and with time. But if it is pathological, it should be treated well either by phototherapy or blood exchange, because it can lead to brain damage. So the differentiation between the pathological and physiological jaundice is important, as the treatment is completely different. Some of the skin manifestation, common skin manifestation, is like the acne neonatum, which is occurring about 20% of the newborn and present as closed condoms and on the forehead, nose, and cheeks. Neonatal acne is thought to be the result of maternal or infant androgen that stimulate the sebaceous gland. It's also a self-limiting condition. And these are the skin manifestation. Always the family are concerned, and we are reassured the family and give the advice that most of these are not need and treatment. It will resolve by itself. Melia, very common, and we are seeing this in many infants after birth, and it is resolved by itself also. Again, another skin manifestation, the erythema toxicum, also known as newborn rash, and it's common rash that affect many newborn. The rash generally appear on the face or the midsection of the baby body, but it may also appear on their arms or thigh. It is characterized by yellow to white bumps surrounding by red skin and looks similar to a cluster of flip bites. Usually, within 3 to 14 days after birth, we can see the erythema toxicum, and although it may appear within a few hours after birth, the condition goes away without treatment and isn't dangerous. Again, one of the common skin manifestation is the cradle cap, seborrheic dermatitis, and we saw this in more than 50% of all infants. It is not harmful, and it can be solved by itself, or sometimes we are using certain cream and shampoo to solve the condition. The type of the breathing of the neonate is also concern the family and the mother, because we know that the child is getting different pattern of breathing than the adult, and this type of periodic breathing, we need to clearly examine the baby and assess the baby, and after we found it is a normal phenomena, we need to assure the family about this one and need to differentiate between this one and the apnea of prematurity, the transient tachypnea of the newborn, and the respiratory distress syndrome. Vomiting and regurgitation. This is a common problem. The family seek for consultation for regurgitation after birth. And there is a lot of causes for vomiting and regurgitation. I'm here just saying that this is one of the common problem. If we want to go through the all causes and the reason behind the vomiting and regurgitation, it's a long list, but the most important is to differentiate the normal regurgitation from any GI obstruction, raised intracranial pressure, CNS infection, asphyxia, sepsis. These are the very important things to differentiate between the normal regurgitation that we saw in many infants and the disease one because of the obstruction or CNS infection. It's very important to assess the baby that the baby is passing urine within the first 24 hours. And this is one of the common things that we are during follow-up of the baby to assess that, to be sure that the baby is passing urine. If not passing urine, then we need to, again, to assess the baby. And first of all, we need to check the bladder, if it is full or not. And then if it is baby is not passing the urine, keeping not passing urine, then we need to go to investigate the baby and to check the renal system for any abnormalities. Same like the passing urine, also the failure to pass meconium, and more than 99% of term infant and 95% of preterm infant passing the meconium within the first 48 hours of life. The failure to pass meconium is very important, and it should be taken this consideration as a highly priority, and check the baby for any imperforated anus or functional intestinal obstruction or any illness or any other causes for failure to pass the meconium. Jaturnus, which is a tremor that is stimuli sensitive and can be stopped by passively flexing the affected limb. And I mentioned jaturnus here just to differentiate between jaturnus and seizure. And in seizure, even if we are holding or passively flexing the affected limb, it is not stopped. So this is important, and one of the common causes is to differentiate the electrolyte disturbance, hypoglycemia, hypocalcemia. These are the main reason, pathological reason for jaturnus. Even it is not too much common, but again, we are seeing a lot of cases of foot deformity, and the most common one is the positional deformity. The other one is the clubfoot congenital talpus equinovirus, and these are cases that need refer to the pediatric orthopedic surgeon. Birth trauma and injuries. Again, all the healthcare provider, the midwife, the obstetrician are more than happy to get the baby without any trauma or injury. But in certain situations, and because of the failure of the passing of the baby, or because they are using certain technique for the delivery, like the vacuum or using the forceps, some of the babies are affected and getting trauma. And I will mention some of these common trauma, like the Bell's palsy, which is occur when a baby facial nerve is damaged during labor. In most cases, nerve damage is caused by pressure on infant face during the passage through the birth canal. However, facial paralysis can be also caused by doctors that use the forceps during delivery. Nerve damage is almost noticeable when baby cry, and the facial muscle on the side where the nerve was injured cannot move, and the eye on that side remains open. The Bell's palsy eventually improves without treatment if the nerve only bruised, but if there is severe damage, then it can be a permanent effect. Brachial plexus injury is another birth trauma, and as a result of an injury to a baby brachial plexus. This plexus is the network of nerve that connect the spinal cord to the baby's arms and hand, and brachial plexus is a common occurrence in difficult birth, especially if a baby shoulder gets stuck in the birth canal and the doctor tugs hard on one arm to help extract the newborn. The most common sign of the brachial palsy is when a baby cannot flex or rotate the affected arm. The severity of injury again depends on how badly damaged the nerve area. If the nerves are only bruised or stretched, the injury heals over a period of weeks or months, and arm movement is restored with the aid of physical therapy. Just a reminder that always details history thorough evaluation and complete physical examination are vital for early differentiation from abnormal finding. Proper advice and guidance and assurance to the family is the cornerstone, and breastfeeding and early physical contact should be always encouraged. I don't know if we are asking in the beginning if there is there anyone mentioned the common?
They say rashes, crying, vomiting, and regurgitation.
Yeah, so it's the same what we are mentioned in the lecture. These are the common things that we are seeing in our practice. The skin rash, and these are the family concern after getting the baby. And most of our answer for these things are, this is normal, and it will be resolved by itself. So it's very important for all doctors, pediatrician, and even GPs who's seeing the babies in the first month of life, is to be sure that these are common problem, but it is almost self-limited and does not need any treatment. This is our message.
Thank you. And how common are the orthopedic problems? In your practice, you see a lot of congenital.
We see, but almost it is an positional problem. But again, we see now we are seeing also hip dislocation, all these things. Still, we are seeing this problem. So it's important also to be sure that doing the physical examination, and if needed, to do the investigation, ultrasound or whatever, to improve the diagnosis and refer the cases as early as possible, because this is also will be important for the management and the outcome.
Yes, of course. Thank you. Any questions? No questions in the chat? Yes, please.
We cannot send it to the general surgeon. Pediatric surgeon still is. It is almost and benign things, so almost we are dealing with these cases unless it is need and surgical correction. So I leave the mic to Dr. Suhail, our co-chairman, and to make the pediatric closing remark for the Maternal and Child Health Congress, the second session, the second season, as you say.
I'm sorry?
You say second season, huh? Yeah. So the floor is for you.
Good afternoon, and this will put an end for the pediatric part of the MACH Congress. It was a pleasure to have you all, and I want to thank you for your attendance, and I want to thank the eminent speakers. There was good interaction between the attendees and the speakers. Things went very well, and I hope the subjects were of wide variety enough that will serve most of us and spills benefit on our patients and on our knowledge. I would like to get your feedback through the Zoom, which is available at the Zoom programs, and I am looking forward, hopefully next year, inshallah, that we see you at MACH. Any suggestions, we will look at it and we add it to the MACH, inshallah. Thank you very much for your attendance. Appreciate it all, and thanks enough a lot.